Great. Welcome back to Health Healthcare. We are switching gears and we have Jill Olson, Executive Director, right? VNAs of Vermont. Sorry, I don't have my agenda. Oh yeah, I do have my agenda in front of me. And so we're switching gears to the Budget Adjustment Act. So Daisy is our point person on the committee for Budget Adjustment Act. She's been attending the Appropriations Committee meetings. Later on this week, we'll have DEVA and DMH to come in and talk about their BAA. Today, we have Jill with us because what she is requesting is not included in the Governor's Budget Adjustment Act. So, Jill, I'm going to turn it over to you.
Great. And we don't have it.
You have this. You have. Did you send this?
What you have actually is a memo for me. I sent it to Claire earlier, and then I'm gonna present slides
that have all the information.
That's in the memo.
The memo has more
Information. I'm
Okay.
present from slides just
On today's
level.
calendar thing.
The memo is on today's calendar.
I got it.
Okay. Is everyone good where we are? All right.
I'm feeling good that I have somehow managed to share my screen and not make a terrible echo.
Yes, that's
Yeah, I'm
great.
feeling good for the new year. Yeah. Good afternoon, Jill Olson. I'm the Executive Director of the VNAs of Vermont. Thank you for the opportunity to testify. I want to give a special thanks to Claire, who figured out how to get me onto the schedule. So thank you.
So before I start, I always just like to remind any group I talk to, and you have all heard this from me before, about what home health and hospice agencies do, and then orient you to what I'm talking about today.
So we have kind of 4 big buckets of work: skilled care, home health care, that's medical care at home, nurses and therapists in your home. Usually most often after a hospitalization. We also have a lot of preventive services, health screenings, vaccinations, maternal child health. Long-term care, that is generally unlicensed care. That's personal care, homemaker services, other kinds of things to help people continue to live independently at home over periods of time. And then, of course, we provide hospice services, which is end-of-life services, wherever people are. So not just in a facility, but also in a home or in a nursing home. Lots of places we provide end-of-life care at home. So what we're talking about today is just the healthcare part. So I'm just talking about our skilled home health services. They have their own fee schedule, and so I'm just focusing on that today. Choices for care is also really important, but that will be a budget conversation down the hall. As Nolan said, this is very similar to last year's testimony because the pressures are not getting too much better, but some of them are improving. We're still hiring travelers. So there are fewer. It's looking better. I have new data. I will soon have a chart. I'm hearing anecdotally that it's improving, but it continues to be a challenge. Organizations only hire travelers to preserve access. That's the reason. So if we don't hire the travelers, then it's less care that we can provide. So members continue to do that to try to preserve access to the greatest extent they can. Wages, salaries, and benefits are all going up, and often going up a lot. And of course, we're in competition with other providers, including hospitals, for our workforce. For some of our workforce, we're in competition with other types of organizations, but for nurses, we are competing with everybody, hospitals, nursing homes, and it's a very tough market. As we all know, there aren't enough nurses out there right now. We've had historically low Medicaid reimbursement, which has created all kinds of pressures within organizations. And then we have many beneficiaries migrating to Medicare Advantage. This is a policy issue that we need the federal government to solve. They can pay us whatever they want. They have no obligation to pay us. So it is not unusual for a Medicare Advantage plan to pay less than Medicaid. So think about that. We're taking what used to be our best payer, and it's becoming our worst payer. So it's not true for all Medicare Advantage plans. It definitely varies by organization. But some of them, including some pretty large ones, pay very, very poorly. There is no way the state can regulate them, and we have very little leverage or negotiating power. So this is, to me, the policy solution is there need to be some federal obligations about what they pay us when they contract under a Medicare Advantage plan. But that policy does not yet exist. And I'm pressuring our national association to try to make that happen. I wanted to cross out the Vermont provider tax because you crossed it out last year, and things are not yet good, but they are better. And so you really made a big difference, and I really wanted to express my incredible gratitude that that this body took this burden away from home health and hospice agencies. It was huge. Made a big difference. We're still seeing operating losses across the board, but they are smaller. So like I said, we're not good, but we are better. And I wouldn't ever want you to think that what you've done for us isn't making a difference. It is. It's just that we have further to go. More federal. We live and die by Medicare, and they are cutting us. So we talked about this a bit last year. We had a permanent cut on January 1 of 23. We had another permanent cut January 1 of this year, and we expect another permanent cut on January 1 of next year. They are currently aiming for a 9.48% cut. This goes back to a new payment model that went into effect January 1 of 2020. And CMS believes that they've been overpaying us ever since. So this has been this debate. It's a methodology debate. It's a what is Congress authorized debate. There's a lot of technical stuff happening behind the scenes. But the reality is that they're permanently cutting our Medicare rates. They have phased it in because of all the advocacy, which is definitely better in the short term. But I think it's really important to understand that there's a clawback on the table. And so it's.
Can you explain that?
Yeah, what I mean is they're going to take that 9.48% that they think we've been overpaid every year. And in theory, they could go all the way back to January 1 of 2020 and take 9.48% out of every single year until now, minus the cuts they've made. That's what's on the table. So right now, we're trying to push Congress to at least take the clawback off the table.
I'm trying to understand, Jill, what this is. And when you say, can you easily and not take all day for everybody here, walk me through what you mean by a Medicare cut? How does the money flow?
Oh, I literally mean if they used to pay us $100, now they're going to pay us, I can't do math that fast, but they're going to pay us, $90 plus
When you
dollars.
say us, who's the us?
Home health and hospice agencies.
Okay, so you deliver care for $100.
We bill Medicare.
You bill Medicare
And they're gonna
for
pay us.
$100, they're gonna pay you 90 something.
Well, yeah, they don't care what we bill them. We just tell them what we did and they just give us the rate. There's no negotiation with Medicare. So what they're saying is when we say we did this service, they're going to say, this is how much we're giving you. And it's going to be 9.48% more, less than it used to be.
Okay, less than it used to be. And you are still obligated, obviously, to pay the people who work in that agency.
Yeah.
They're normal.
You got it. That's right. We still got to pay the people. Oh, guess
Right.
what? We got to pay them more every year.
Yeah, you gotta pay
Yeah.
them more, you're getting less for it.
That's right.
And that's the rub.
That's the rub.
I just want to
Yep,
understand.
that's exactly
Yeah.
it. There are a few other complexities, like the rate is made up of other things. So there's a standard rate that's getting cut. There's an inflation factor that they do add on. So the year over year cuts look somewhat better, but they're taking away is this much out of that base rate. And then they layer some stuff on top of it. Takes a lot of spreadsheet to make the final rate. But yeah, they are taking away money from our services. They're paying us less for what we do.
And what justification do they use for that?
It's all about methodology. They believe that their new payment model is overpaying us. It was supposed to be budget neutral to the old model. They think it isn't. We think it is. Our national is suing them. It's a whole mess.
When you say us, it's not just Vermont, it's everybody.
The country.
Everybody.
And suing them, sorry.
No,
So when you said suing them is federal.
CMS.
CMS.
Is the 9.48% the same across the country, or is that Vermont?
Same. And it's been a little bit of a moving target. So it's actually gotten worse every year, their total. They just keep making it worse. And then they cut what they predicted for the rate in half, hoping that will sort of calm everybody down.
So this is a rate cut that is out of our control, but it affects the care and the access for Vermonters to have skilled nurses come to their home. If the skilled nurse isn't coming to their home, the person is staying in the hospital, which is a much higher cost.
Yeah.
Mostly seen in the emergency room.
Or they stay in the hospital. I mean, in Vermont, there's actually some new data out showing that in Vermont, 17% of hospital discharges are to skilled home health. That's a lot.
17%.
To skilled home health.
So that's keeping those people out of the hospital or going home with no care and then going to an emergency room because they need help with that wound or something.
That's right.
Alyssa?
I just want to be clear
Yeah.
that the payment model is being cut. So the rates are being cut, but the inflationary increases that they give you, you're still getting those.
We are still getting those.
We're not.
This is not the year-over-year cut.
4.8 less 3 years later. And not
Getting-
you shouldn't get more.
Getting like, so what's happening is instead of getting like a 4% inflation factor in an 8% inflation environment, we're getting like 2.2%.
Yeah.
Yeah, so the rate is made up of many, that's what I was saying, it's
Going
made
up,
up of
just
many
not up
things.
enough.
But they're taking that base rate and they're permanently reducing it.
Okay.
Yeah. Yeah.
So Jill, with that said, you see these cuts, does that make you lessen your workforce? You can't hire the same number of people, and then you have to say, look, we can't care for you at home, you've got to go to the hospital, is stuff like that happening? Is that to the
Yeah,
extent?
it
that
is
we
starting
are?
to happen, and it's really happening in long-term care. But there are definitely parts of the state where we're struggling to provide skilled home health at all.
Okay,
Yeah, there are no nurses.
because this is the only money you have. Is that
Yeah,
correct?
well, there's two issues, really. There's the money issue, and then there's no nurse available at any price
All
issue.
right, yeah.
So there are places where we can't even get a traveler. So there's nobody. It's a multifaceted problem for sure, but losing revenue is not helping.
Yeah.
Yeah, and I think just going back to something that Representative Houghton said, just that pretty much everybody who's getting skilled home health is a person who's not in a nursing home and not in a hospital. That's the other place they would be. That's the other place they would be. So, because skilled home health is intermittent care when you have an acute problem. This is not long-term care. This is like something immediately wrong with you. And you need services for 30 or 60 days on an intermittent basis.
Jill, on the 17% that are
Yeah.
being discharged to skilled nursing, do you have data that shows what the savings is to the system by them not being in the hospital?
I don't have that, and I think it would be, I'm sure it's an analysis that could be done, but probably by an analyst, not a lobbyist, like me. Because, of course, it depends on like, what were they there for, and, and how long would they be there, and what unit would they be on, and all of that. I mean, I'm guessing the hospitals have a way to sort of estimate what it costs them when someone is awaiting discharge who no longer needs that level of care.
But at home, I've just met with some of the hospitals. If you get some of these elderly into the hospital, they came from a nursing home because they broke a hip. The hospital doesn't get reimbursed for that.
Right, when they're just staying in the hospital, that's right, it's kind of,
Go back to a nursing home, there's none available.
Right.
that's right,
They're at the hospital for a long time.
that's right, that's exactly right.
Yes, that's an additional cost.
It is.
Yeah, because that hospital isn't getting reimbursed either.
Yeah.
Listen.
So I remember specifically last year, we had talked about, because we have this issue of boarding in the ER, in the ED. Because you can't get an inpatient bed, because you can't discharge somebody, because there's nobody in the SNFs. And
This is
skilled nursing, sorry. And you can't get somebody. And so the question was, is the skilled nursing facility full because we can't get home health care? And I distinctly remember last year you had sort of said that at that point, none of the agencies, the VNAs, were turning people away, that you were still able to provide care to people that needed skilled nursing. And I wondered if
That has changed.
that's changed.
Yeah, things have changed since January of last year. So so in the Windsor County, Wyndham County, where Brattleboro is, Wyndham County, sorry. my agency there is not able to find nurses to provide skilled services. So Biata is still there, but there just aren't enough nurses in that community. So they have actually, and they were operating an incredibly high loss, but they couldn't find a nurse, even a traveler, for a place like Peru, Vermont. So that has changed since January. The other thing that's changed is the Franklin County Home Health Agency. Their service area is going to be taken over by the VNA and Hospice of the Southwest region. So they run the agency in Rutland and Bennington, and Franklin County's agency was in serious enough trouble that that agency actually, it's really the service area is moving, not the agency. It's not a merger. The agency will technically no longer be an agency, but I just want to be clear, another agency is taking the service area. So I don't know how many rabbits like that are left to pull out of hats. It's all about dollars and cents.
So the Rutland VNA is taking over?
Yeah, they were the one best positioned. They were the ones best positioned to take over that territory.
Really?
Yep. And we are extremely lucky that they were willing to do so.
A long way.
Yep. So they're retaining the staff, they're retaining the patient. I mean, they're doing a really good job of keeping a continuity of care in that community, but it is really, to me, a serious indicator of just how rough it's getting out there fiscally.
All right, so let's hear what you're asking.
Okay, so here's what I'm asking for, $253,000. So this is in the BAA. So that's the general fund
So wait,
number.
let me rephrase something you just said. It is not in the governor's BAA.
Not in the budget.
So this is an additional request that we will make a decision on to send to appropriations.
And this is what will help alleviate some of the problem.
We'll let Jill answer that.
Okay.
Yep.
Yeah, so what we're asking is for you to bring our skilled home health reimbursement rate for Medicaid to 100% of what we call LUPA, which is our Medicare fee-for-service fee schedule. So let me just back up before I explain that.
Yeah.
So the 253 is, just to be clear, it's half a year state only, because this is a matched program. So the 600 is the total that will come to home health with the federal match, unless I've gotten my match stuff wrong, and Nolan will tell me, but this is, if I've had these numbers wrong, they're not super wrong.
Okay.
And then that is a half a year, because this is, of course, January to June. On an annualized basis, it's twice that. So it's twice that on an annualized basis, but the BAA is only till June.
And you have to come in on the BAA request because of the way you have your.
You're now on a January 1 cycle. DEVA moved us to a January 1 cycle as part of a project to try to get us up to 100% of LUPA, and the plan was to try to do increases on a regular basis.
So I just want to make everyone understand that. So we do the budget, which starts on July 1st to June 30th of the following year. So normally when we do the budget, people get funded for that whole year. Since they're on a January 1st to December 31st calendar year, they only get funded for half a year. Is that correct?
If you do it in the BAA,
you
yes.
do it in the BAA.
Yeah, and then it has to carry over into the next budget. It becomes a budget issue for the next budget as well. Yep. So that's why I want to be clear. It's on an annualized basis, it's twice this, but in the BAA, it's this much.
Yep.
And so I have numbers from DEVA, so I believe I have them right, but of course I always defer to Alicia Cooper.
Yeah. Absolutely. We all do.
Exactly. So so what this would do is bring us to 100% of the fee-for-service fee schedule. So Medicare pays us in two ways. The Medicare payment model that we have has what they call an episodic model, where they say, you're taking care of a person with these needs, we'll give you this much for the whole episode of care. So that might be 6 visits over 30 days. And then if it's a person who needs only a few visits, that flips us to what they call the low utilization payment adjustment, or LUPA, and that's a per visit payment. The per visit payment model is generally lower than the full model, where you've got both the per visit and the episodic together. So our national estimates that it's probably about 75% of all LUPA payment is like 75% of a true Medicare payment. very hard to do on a state basis. There's a lot of other complexities, like we provide services on Medicaid
That are not allowable under Medicare that probably do make sense on a fee
for service basis, so you can't just like, it's not really one-to-one, but just to give you a sense, what I'm asking for is 100% of a low fee schedule.
Okay.
You have many other groups that you brought to 100% or even more. The physicians were at 110 last year. So you brought us to 90 last year. Because LUPA actually is a piece that is the fee for service part is not affected by that cut. It's the episodic that's affected by that cut. LUPA did go up. So we're now at 88. It's the same, the dollar amount is the same, but the percent against LUPA is a little lower.
So right now your reimbursement is 88%.
About 88%.
And you wanted to bring it up to 100%.
Right, we were at 90 last year.
And you went down to 88.
Yeah, because LUPA went up.
It went up.
Rate didn't change. Its relationship changed.
Yeah.
So what we're hoping to get to is a place where we're at 100% of that rate schedule, which could then tie the LUPA going forward. And similar to how hospice works. So our hospice, there is an increase for hospice in the BAA, and that's because there's a federal mandate. So our Medicaid, there's a federal mandate for the Medicaid rate. They have to match Medicare. So that one has to happen, and it does. So that's $25,000 in the BAA. Our Medicaid programs are pretty small compared to Medicare.
Medicare, okay.
Yep.
Any,
That-
Leslie, you had a question? And then Nolan.
Go ahead, Nolan.
You probably just said this and I missed this. Is this money for January to July or January to December?
January, July. It's twice that for January.
Okay.
Yeah, because the BAA is only till July 31st.
And they gave you the wrong FMAP, I'll give you the right one.
Okay. Is it very different?
Right.
Okay.
Is the 253 still the same?
The gross will be the same, the general fund will be different.
Okay, so if you could just get us the right number.
Yeah, they give you the 25 FMAP.
Oh, for this. Okay, so we'll talk.
All right,
If you could just tell me what that is, I'll fix my testimony for tomorrow.
Leslie and then Art.
I think I'm confused and it would help me to see a chart or something. I'm not understanding, I think, about the half year and how can we get on a whole year and not have to do this BAA thing every time? Is that the only way that we can do this, is to every year ask for a BAA allocation to make up the difference as opposed to having it embedded?
Well, so the alternative would be for the budget itself to assume that we were going to get some kind of increase on January 1st, budget for it, and then provide it for us on January 1. That, you could do it that way. Or you could change us to July. Those would be options. But because we're at January 1 and that's sort of when we turn over, and there's nothing in the budget or the budget adjustment, nothing in last year's budget assumed this. And there's nothing in the budget adjustment that assumes this, we need to ask for it at this moment. But the BAA is a half a year of money. It's the current fiscal year.
No, I understand that part.
Yeah.
I just want to get beyond, I was just wondering if there's a pathway to get beyond this kind of.
That'd be a question for Diva, if they're willing to go back to a July 1st year versus a January 1st year. So we can ask Diva that when they come in.
Oh, right. That would just get it on a budget cycle. That would
Right,
take it off.
track with the hospice rate, which was the point at first, was to try to keep it on track because the hospice turns over January 1 and also our Medicare turns over January 1. So the idea was to keep all those things lined up.
right.
But they don't need to come back for a BAA request because they're fully funded?
Because the hospice is a federal requirement.
Yeah. There is a hospice allocation in the BAA.
So the other thing is, our intent, which does not have to be adhered to, is that they are at 100% always. And so we stop doing this.
Yeah, I mean, that's what I'm under, right? If they were 100% all the time, then we wouldn't have to go through.
Unless they want to go to above 100%, right? But yes, right?
Yeah.
That's what we're looking at. Art?
Yeah, and this may be for you as much as anyone, Lori. I don't know what the DIVA budget is in the budget. I don't know how much money we allocate or has been allocated by appropriations for DIVA. But does that get looked at to see if there's $250,000 and then not spent that could be put into this? In other words, move from one pot where, gee, we couldn't find 3 or 4 employees.
Right.
And now take that money and put it to this instead of this constant,
Adding.
we need more, we need more, we need more.
Right, well, that is not what the administration did, right? So they looked at they gave their recommendation for a budget, which might have done that for other things, and they chose not to do this funding. So now our role in this room is to say, do we believe that this funding will help Vermonters? Look at our guiding principles. Is this appropriate? Does it help the system of care? Does it help bring down the price and the cost of healthcare on one side by elevating something over here and keeping people in their home? If we believe that is a good policy decision, we send that to appropriations and they determine whether or not something gets cut to add this or if this is just added on top.
I have to tell you, I always have a hard time separating.
I know you do.
We do these things and pretty soon they become a mandate to somebody else and they just get funded. And that's just my own personal, but.
You know, it's not, I mean, I know, and I get that it's a struggle every year, that we are putting forth policy initiatives that cost money, and then we send it to another committee to figure it all out. But we are the experts in this room on healthcare in this building.
Yeah.
And when we look at the whole system of care, we have to think about, and individually, and make a decision.
Yeah.
Where this fits and how important it is or not. Yeah, it's hard. Yeah.
I was just wondering how much the administration request in the BAA was for the hospice?
About $25,000.
25,000?
That's what the rate, so the rate
changed enough.
Yeah, so I got the rate increase notice, the GCR it's called, yeah. So I got that notice at the end of December, and it shows what the change is, what the impact on the budget is, and it was $25,000. And I believe that is, yes, I cited it in my memo. It's in the BAA.
Thank you. Ellen?
I think you mentioned this earlier, but this 600,000 or 253 plus.
Yeah.
It's going to go to how many different parts of your agency? Hospice, visiting nurses?
Only the skilled nursing.
Okay,
This is
just
only
skilled
skilled,
nursing.
yes. Not long-term care, not hospice, not prevention. This is just skilled. This is people getting discharged from hospitals or having some preventive care to keep them from going to hospitals, but it's the skilled care, nurses and therapists.
You know, we talk a lot, public media, everyone talks a lot about affordability and access in healthcare. And so I'm going to challenge all of us this year to look at those two things when we hear requests like this, right? And don't look at it as just this one thing. But how does this decision affect affordability and access across our continuum of care, right? So we don't do this. Some people aren't able to get the skilled nursing that they should have access to keep them in their homes, to keep them healthy. So now they're in a nursing home or a hospital and the hospital isn't getting paid. So then the hospital has to go and ask for a larger rate to Green Mountain Care Board. So I mean, like, we got to start thinking about all these steps. And I'm not advocating that we do this. I'm advocating that we think through all of the steps and the process and the system as these hard decisions come before us, because healthcare is expensive. And if we want people to have access, we have to be willing to make these hard decisions. So just as we start the BAA process, that's my little rant, my little guidance, I will say. So,
Oh, it's a rant.
it's a rant. My guidance. Any other questions for Jill?
Give one more.
Yeah.
Out of your skilled nursing,
Yeah.
is there any that are the traveling nurses?
Oh, yeah, there's travelers.
You know what percent?
I don't know yet. I just collected new data, so I'm working on compiling all of it.
And
Yeah,
I think you said at the beginning.
It's
there's
better.
travelers, but it's better than it was.
definitely better. People have made it. I mean, we've got some huge sign-on bonuses out there in order to make that happen.
Yeah.
You know. So yeah, it's not easy, but
There's been a lot of effort to,
Root is
particularly, I talked about a number who's really struggled. I mean, her recruitment efforts are huge and
still struggling because again, sometimes there's no nurse at any price.
Yeah.
But I would say we're the best deal around.
just
I heard-
laying out the rant.
I heard over the weekend that one place, not in Vermont, was offering $40,000 sign-up.
Sign on.
Wow.
I mean, we know we have an agency who has been offering $30,000 sign-on bonus for home health.
Wow.
Yeah, that is the level of competition that we are all dealing with. It is absolutely, please tell your children and grandchildren to become nurses
I know.
right now.
That's double my onions.
Right now.
That was my question, if you've seen any, I know we're working on workforce development,
Yes.
and also in colleges, are you seeing any, is there any data or statistics coming out of like, the programs that we've been?
So I would have to leave that to the administration that's sort of running all of those programs. They are helpful, but I would say they're relatively modest given the size of the problem.
And we're gonna do some workforce work with House Commerce at the end of next week, I hope. That'll be a first step in looking at the programs and see where we are with all of them. So, and I'm sorry, I think someone else over here had their hand up.
Raise my hand because I think what you said was really important, almost to the level of a guiding principle. How does this decision affect other parts of the continuum of care? I think that would be worth adding.
Well, if you actually ask the question, if that person's in the hospital or in their home, you can answer it pretty quickly. It costs less to be in the house than it's gonna cost to be in the hospital.
Yeah.
And it's much better.
Much better.
And you're gonna, probably, yeah.
All right, so Jill, thank you. Thank you very much. So just so the committee knows, as I said, we'll be hearing more BAA and we will have a conversation Friday afternoon about what to do appropriations.
Oh, I have to stop sharing, sir.
I think you did.
Well, all I did was, I just closed my thing. Yeah, now who knows what it's gonna show you. Oh, boy. Okay.
It was good. It was just
My snoo shoes or my mountain bike I'm dreaming about. or-
Hey, go to Kingdom Trails.
No, and I support this. But I also like to say, when we do this, that's fine, but, you know, we've had programs in the state paying college education if you become a nurse, all right? Some of these got no strings attached,
yes.
okay? So how does that help this?
Most of them now have strings attached,
Well-
but we will be reviewing that when we
Okay.
look at the workforce stuff. So remember that.
Well, oh, I forgot.
I won't either.
Okay.
That's what part of my question was.
Okay.
We will be looking at all of that. Great. Thank you, Jill. Okay, so now we are moving on to teachers' health insurance plans, just a committee conversation to actually get an update from Bobby. So teacher health insurance plans are the jurisdiction of the House Education Committee. I want to be clear on that. So when they were, but we're all hearing that healthcare has gone up for the teachers and for the state employees plan. And so when education was going to have them in, the chair reached out to say, do you want anyone to sit in it? So Bobby sat in. So I was hoping Bobby could give us a brief kind of synopsis of what you learned, and then we can talk about it for a couple minutes.
Okay, I did sit in for 2 different sessions, and I think it'd make more sense if I cover just a little bit for a minute about how these plans are negotiated.
Great.
And it used to be district by district when I was on the school board, and that apparently the year after I left the school board, it changed to a statewide commission.
Yes.
And that commission has 5 members that represent the school districts and employers, and 5 that represent the school employees. And, you know, based on what I've heard, it sounds like the employers would like to go back to a district by district negotiation because it seems to be working out that the actuarial value of the teachers' plans And I'm not, I don't want to sound one-sided on this, but they've gone from covering 75 to 80 something percent to over 96%. So basically what the teachers are paying is a smaller and smaller percentage. And that adds to the cost that the school districts are paying. But
When you say employers, that's the school district.
yeah, that's the school district. So they have five, the reason why they think it's not working out is that they have five on each side, but when it comes to they never often come to an agreement. So they have arbitration from the Vermont Labor Relations Board. And the way it's set up, there is no way to pick and choose parts of each side's plan. So it's either all or nothing for either side. And the teacher's side has been winning in the sense of getting their plan. So I don't want to sound like I'm dissing what the teachers get, but it does seem like it's been favoring the teacher's side, and that has caused them to pay a smaller and smaller share of their own health care. Now, that's one piece, but that's not the full picture as to why the costs have gone up. That was the first day that I covered that, how it's done. The next day, we heard from VHI themselves, and Mark
Can
Hagan.
you say what behind it is?
Oh, sorry, the Vermont Employees Health Insurance Program, and it's an organization. Blue Cross Blue Shield administers the insurance plan, but this group oversees and basically determines what that plan includes. And their administrative costs are low, like less than 5%. So that's something that's positive. 89.9% of the money that is spent on it goes directly to care. But what's driving the costs up are basically two different things. 55% is hospital costs and 20% is drug costs. And the drug costs are what keeps going up. There's a lot of explanations for that. For example, a lot of these drug companies that could be allowing their patents to get generic, find ways to get their patents renewed, shield themselves so that they can charge higher amounts for this. And some of the numbers were staggering. For the average participant in the health insurance policy, the average participant only costs about $150 a year in prescription costs, but there's a small subset that costs about $50,000 a year. And that's just because they have illnesses that nobody has any control over, which require some of the most expensive medications ever, sold on the market. And there is issues with the pharmacy benefit managers involved in this. Because they had to hire a separate consultant to renegotiate prices on drugs because they were getting fleeced basically by the PBMs. And so there's where there's room for improvement right there. With the hospital costs, that's a little more complicated because of what you just mentioned earlier about why hospital costs are going up. And that's something that the VHI can't control either. But it feels like all of us, all the taxpayers, are at the mercy of the drug companies right now for the cost of these plans, based on what I understood. And at the end, I did bring up a couple questions. I was allowed to ask a couple questions at the very end because Mark Haig of the VHI, who did the most of the explanation, talked about reference-based pricing that our state auditor has also mentioned as a way to save money. And he brought up what's going on in Montana, where they haven't had premiums go up for many years now. And they're somehow keeping their costs under control. But I asked him, how does that interface? Because that whole reference-based pricing sounds like it's based on the fee-for-service model that our state's trying to move away from. So how does that work in a world where we're trying to have the all-payer model? And he sounded pretty skeptical about the all-payer model as far as it being able to control prices. So he didn't have a definitive answer, but I was trying to put that in there because that's stuff that Education Committee doesn't normally deal with, but we talk about it all the time. So the drug prices is one of the big targets that I think if we were talking about bringing down costs for taxpayers, that's where the biggest inflation is happening.
And so thank you, Bobby. That was really great. And we're going to go to questions in a minute. And Mario, I know you have your hand up, but I just want to say that, so it sounds like that the same reason premiums and healthcare costs are going up for everyone else is the same reason it's going up for the teachers, and it's drugs and, specialty drugs and then hospital costs.
And more staff. We're hiring more teachers, which is going to require more insurance.
Well, I mean, we don't know that. We don't know the numbers of what everyone's hiring, but that is an assumption, potentially, yes. Hold on, I'm going to let Mario go first.
I'm sorry. Yeah.
Thank you. And Penny, to your point, I'm not sure that there's more staff being hired since we've heard recently that the student enrollment is down. So I think we would have to get data on that to be sure of that. But I do want to thank you, Bobby, for that important information. I think you nailed it about and the education committee did about it's the drugs, it's pharmacy, and the hidden money, the money that we can't see between what PBMs are paying pharmacies and what the insurer the price that the insurer has. So there's that black box that we've talked about in the past. So I'm just pointing out, this is an area that we can get at in Vermont. And we'll talk more about it with the PBM bill, but we definitely need to look at the numbers with an audit, see what, for example, the teachers, VHI, really, since they can't see the difference between what Blue Cross Blue Shield is paid and, for example, what a pharmacy gets paid for the same medication. And there's a big gap there. There's money there that Vermont is losing. So, and I just finally also would like to, this is an editorial comment. Educators need health insurance. Everybody needs health insurance. So it's not a bad thing. It's a good thing that teachers are getting health coverage in their negotiations. And one of the concepts that was brought up that I think we need to pay close attention to is how health insurance and health benefits are bargained. That's a little bit it's definitely out of our purview as a committee, but as legislators, we need to pay attention. There's a concept that we should either, that the state employees and the teachers should bargain at the state level versus at the local level. And I heard a recommendation in that one of those meetings you attended, Bobby, that it should be done at the local level. And I don't think that's a good idea. That's it. Thank you.
Okay, we're not gonna comment on that last piece. We're gonna all hold our own opinions on that. Hold on, we got a couple of questions, and then you can explain. Art, and then Alyssa, and then.
Yeah, Bobby, I didn't know if they talked about it, and to kind of piggyback on what Mari was hinting at here, the percentage of increase caused by the teacher negotiations versus the cost of drugs or cost of service. Any idea where the most growth of the costs are?
For the insurance plans, it seems like drug costs and hospital costs are the biggest growers. Okay. And, to be fair, that whole thing about the actuarial value, that was coming from the perspective of the folks that represent the employers. That wasn't from the teachers did not answer back from that, but that was the stats that they provided in their testimony. But as far as the cost of the insurance plans in general, it's the drugs and the hospital costs that are driving the increase in the plans. And that's why, like Lori said, it's the same for all of us who have private insurance, the same as what the teachers get. They're still paying those same prices that everybody else is on other plans.
But they're getting plans they're getting negotiated plans that pay for 90% versus, like you said, 75%.
Yeah.
I wonder how much that adds to the cost. That's kind of what I was getting.
Yeah, I mean, I don't have the numbers, but yeah, I think it's the results of this negotiating process.
That's right. I know.
The one thing they said that I thought sounded like somewhere where we can investigate was that, and I don't even know these terms, I just learned them about baseball arbitration versus is another term. It's like winner takes all, kind of like,
right.
Versus the ability to say, okay, this side has this idea for this section, we'll use their idea for this, and we'll use this side's idea for this, and that's not possible with the way it's negotiated. So it's all one side or the other gets all of what they propose. And it just makes it hard there's not a lot of room to move, which is why it always ends up going to arbitration instead of them coming to a mutually agreed upon.
Yep.
You know, that's my understanding, and that's as it was presented to me.
Right,
Alyssa?
thank you.
You had mentioned that VHI has 5% administration. So is the 5% what VHI gets and then VHI uses that to pay Blue Cross Blue Shield to administer?
It's in their testimony, but I forget the pie chart, but I think it's in there.
Or does Blue Cross have their own administrative costs?
There is a percentage that goes to Blue Cross and Blue Shield for administering it, but VHI's itself only is 4.9% for them running their operation. So the other percentages, I don't know exactly how they break down, but it was almost 90% goes directly to care. So
some of that is going to be high and some is going to Blue Cross Blue Shield.
and other
administrative
consultants and other things like that.
I think you said it was in the testimony, right?
Yeah, there is a pie chart that if I can find, it's right there. I have it linked in, but it's on the page for the.
They talked anything about the administrative costs to administer their HRAs and HSAs?
Well, yeah, Representative Mary Catherine Stone actually asked about that, and I think it was a small percentage. It was like the debit card, you know, the fees for the accessing the accounts at the banks, and it was a very small number, like 2%, I think. So on the transactions for HSAs and things like that.
Yeah, I think if I'm not mistaken, I think they have third-party administrators who Blue Cross will forward their claims to the third party, and then the third party then will pay the claims out of their health reimbursement accounts. And I'm certain that they have a separate cost.
So I'm going to suggest you look at the pie chart.
Okay.
Yeah, I know.
Right here on,
We don't need to go into those steps.
Calling off.
like this, but.
I'm kind
Yeah,
of,
it's
kind of like-
Kate's testimony had the pie chart that shows exactly how
Right.
it breaks down. Part of, like, they have a small portion that goes to the wellness program, which is like preventative.
Right.
You know, so there's like 1.4%. State and federal assessments. So, you know, it's a variety of things.
Can you just tell us, for those who want to look it up, who the witness was or what it's under?
Yes, Mark Haig and Bobby Joe Sauls, the VHI Trust Administrators, and it's on Friday's agenda, you know, list of documents for
Great.
the Education Committee. You can find the link right there, and they stuck pretty well to what they said was almost exactly what was on this document as I followed along. The only thing that's not on here are the questions that we asked at the end, and you can find that on YouTube, but,
Okay.
the one I asked, I told you about reference-based pricing and the all-payer model.
Great. Alan?
I'm all set.
Sure.
Yep.
So again, generally, this is not our purview. Obviously, we'll be looking at a pharmacy benefit manager bill. I've said this, I don't know if I've said it to the whole group. I'm having some conversations to learn about reference-based pricing. That is a very, very big policy decision. That is not just about saving money. That is about changing how we pay for healthcare and what we're trying to do. So I'm just gonna be really honest. I want to learn all I can about it before I bring it into the committee. And it's not something we would really have time to do this year anyway. So we're gonna know that it's out there, put it on the back burner, and hopefully maybe at some point look at it. And I'm happy to share what I learn as we go along on that.
I think a lot of us are gonna find our constituents will make this something we want to know about. This particular issue.
On the healthcare, yeah, well, I mean.
For teachers.
And we do know about it. I mean, it is their costs are being driven by the same, or their issues that are driving the cost of healthcare, are the same issues that are driving the cost for Blue Cross Blue Shield, for MVP, for everyone, right? So, it's an issue. And yes, we have to find what we can do in the capability of what is available to us as state legislators versus what happens at the federal government. And we just got to keep chipping away. So
I'll say it now. If we look at we know it's an issue. And as far as teachers, when I say new teachers, if we have in each supervisory district, 10 teachers retire, we replace them with 10.
Okay,
So they're not new, but they also, we're still paying for the retired teachers.
yes, that is a separate, yes.
It is, but it still costs the healthcare.
Yes, it does. And that,
And the state of Vermont's got 54 supervisory units.
right,
We've got more than the state of New York. So when we start talking about money, we can save money. We make the right decisions.
and those decisions are not in this committee.
I
But
know
as a
that.
legislator, you can go talk to others who can make those
I
decisions. How about
understand
that?
that.
You know what, you could put in a bill.
But it affects us.
Yes, it does. I know, but it's, unfortunately, we are still siloed.
That's why I said
and
I'd be
not
quiet.
Our decision. No, it's, you know, it's really hard and it's gonna get, it's hard. I mean, you know, we all pay taxes, right? But we also need a well-educated, children, kids. I mean, you know, they're our future. And it's really important that and we have very high graduation rates in this state. Our test scores are good, kids are doing well. And, you know, so it's a balance, but we have a public education system for a reason. So. Okay, thank you, Bobby, very much for that.
I can give anybody else any more notes if they want. My notes are kind of scribbled, but if anybody really wants them, I can try to put them into a legible form.
And Colin is sitting here very nicely. I'm sure he would be happy to talk to anyone outside of committee. So if you've never met Colin, do you want to do a quick introduction?
Sure. Colin Robinson, Vermont NEA. Good to see many of you. Good to see some folks I haven't had an opportunity to talk to, and obviously represent public school educators, teachers, and school support staff. So deeply engaged in healthcare policy conversations over the years, as well as negotiations, and happy to supplement any of the points that have been made today.
Great, thank you. All right, so now we're going to do one last subject before we go home. So we had testimony with House. Are you guys okay? Do you want to do like a 5-minute break?
I'm okay.
Okay. Thanks, Colin. So we did the joint testimony with House Corrections on healthcare in prisons. I thought it was very interesting. I know for some it might have been hard to follow. There was a lot of, you know, we didn't go through the witnesses we had scheduled. It became kind of just question and answer, which honestly, I think for the first time was good, right? Like they don't do healthcare and we don't do corrections. So I think a lot of people just had to get some questions off their chest, and I thought that was good. That meeting was the first in what will be a long process. So, and Tupper might be able to help me here. So this came to us from the Joint Oversight Committee that they did some work over the summer, and they looked at healthcare in prisons from, I think, a cost perspective, right, mostly? Or did you take testimony on?
And cost and whether or not they really were getting the health services that they were supposed to.
And so based on that testimony through joint oversight, it was deemed that there was more, correct me if I'm wrong, there was more oversight that could be provided and more that had to be dug into to answer those questions.
And also the question of when the incarcerated person leaves the prison, what happens to the health care that they're supposed to be, that they need? And who takes care of that for them? They can't do it themselves. They're inside.
And then they're outside.
And then they're outside. So the new contractor that we have to provide that is supposed to be setting up a plan so that doesn't happen. And the problem that you have to overcome is sometimes the judge in a case will just release that person at a certain day, and they have no time to plan for for the transition of that person from the prison to everyday life. That's a big issue.
Yeah.
That they're working on. They're trying to fix it.
So, and, you know, obviously there's been news over the years of people dying in the prisons or people coming out and saying they didn't get the health care that they needed. They have chronic conditions. We have a large older population in our prisons, so that doesn't help. So this came to our committee and House Corrections to say, all right, you all basically need to look at this. So there is no bill. There is no predetermined outcome. This is conversations we're going to have to learn what's happening, learn what's working well, learn what's not, where are the gaps, like you just talked about getting out and what happens. And then, is there anything we can do in the short term? Is there anything that has to be done in the short term? And then are there any long-term things that have to be done? Do we have to put in more oversight over WellPath, who's our contractor? So like, this isn't something we're going into with any answers already, right? This is all, let's figure this out together. And it's going to be important that we do it with corrections for at least a little while to both understand what the other one already knows, right? And so like, we have to understand what happens with healthcare and corrections, and what the corrections process is. And then the corrections has to understand, well, how is this different or not different from what happens with healthcare in the general population? So that's kind of where we are. But if anyone has any comments or feedback or questions, or like, let's just open it up for discussion.
I don't know why, but when they're incarcerated or detained, and if it's a young man, 26 or under, he's covered by his family's insurance. They go to the hospital, what agency said if they can't bill the insurance company?
So if someone is detained or incarcerated, they lose their Medicaid or Medicare, right? They could still potentially have private insurance, right? So we have to separate those two because it's very different between the two.
So if they had Blue Cross Blue Shield, they could be covered. But if it was Medicaid or Medicare, federal or state, it's not okay.
Yes.
What's the reason for that one?
So federal law. Federal law. And you know, it was interesting that they said during the testimony, and this is something that we need to get answered because I'm not sure it's 100% accurate, that if someone goes into the hospital, that then Medicaid could be charged.
Yeah.
That doesn't make sense because you're kind of going, like, we
Can't re-enroll them that fast.
Right, we know.
Or see a specialist.
Right.
I mean, just go to a specialist office visit.
Right, we know that Medicaid's not that easy to get in and out of. So it's easy to get out of, it's not that easy to get back into. And right.
And Medicare, I mean, that's what I couldn't wrap my.
Right.
Because there's a premium for Medicare. You can't just call and say.
Right, I want this
I
covered.
want this back today.
Right. So, Phoebe?
Has there been any planning about where to begin the conversation and structure it in terms of, are we going to define what the problem is to sort of guide the line of questioning between our two committees?
I'm sorry. Topper very kindly was saying something to me, but then that made me miss my questions.
Has there been any conversation
Starting point.
to sort of structure where to begin the conversation? For example, have we defined what the problem is? Because I think that maybe the healthcare committee might have less insight as to, for example, what's in WellPath's contract. And the corrections committee might say, well, the problem is WellPath, this is purely hypothetical, isn't meeting the obligations of their contract. And we might say the problem is 85% of people who are incarcerated are not getting the level of care that all of us can get here.
Right.
So I think I'm curious if there has been any plan or talk about a plan where we would say, you know, have the joint committees articulate what the problem is to sort of guide our conversations.
So yes, but I think we have to get to what the problem is.
That's what I'm at. Yeah.
Okay, we're not there yet. So I think we heard, and we'll do it again in a much more structured way, what DOC believes is happening. And then I think we together as committees need to hear what WellPath says is happening. And based on those conversations, we then need to pull out where we think there might be really great things happening and are fine, or where there might be some discrepancies in things that are happening, or where there's clear gaps and things are not happening. And then determine what committee is responsible for that, and then go on as separate committees. Like, we're not going to do every joint, every the hearing as a joint, but we have to still for a little bit.
So, I'm sorry.
No, go ahead, and then we'll go to.
Who is WellPath accountable to?
They are a for-profit company.
They are, but don't, they.
They have a contract with us.
the Department of Corrections?
Yes,
So we are their boss, I
Yes.
see. Okay.
within the confines of the contract, exactly. So is there oversight we need to put, from a legislative perspective, is there oversight we need to put into place? Leslie and then Melanie?
Thank you. I know that Justice Oversight met over the summer, and I was lucky enough to attend a couple meetings, but I didn't know what Justice Oversight was asking us to do as committees. And that was a little confusing to me, so I would be curious to know if we were being asked specific questions. And you had mentioned what's working, what's not working. I know that there was some charges, but it would be great to have that.
I can send you the letter.
Yeah, that would be great, that we could all see, you know, what came out of Justice Oversight. And that sort of, I think, is the underpinning of why we're meeting as the combined committee. The other thing that would help me, and I don't know about others, I don't know too much about the Department of Corrections. So we had a conversation about infirmaries versus this versus that. And, you know, each prison, is that the right term, has a different sort of healthcare setup. So I don't really understand the healthcare system in the prisons at all. So
None of us do.
yeah, so to have some kind of understanding of that would be helpful to me. And I was just thinking, and I had mentioned this to you, like to have a one pager, you know, what are the names of the prisons? Well, how many beds do they have? How, you know, how many infirmary beds? What's the staffing? I mean, and I guess you may know all that, but I felt a little sort of confused coming out of there, just not really understanding the.
DOC website has a lot of good information. Highly recommend.
So if you just put my care, I get that, and we could do the research independently, but I want us all to be on the same page. And I don't think we are at this point.
Well, and I absolutely agree with you, Leslie. We've had one meeting.
Yeah,
about
get
this,
it.
Right?
Yeah.
Like, we are not on the same page, and it is going to be a process to get us, and I won't even say we'll ever be on the same page, but at least Mari, I see your hand, understanding of the process. We are really early on in that.
From a data point of view,
Right.
what is the system?
Right.
Yeah, and, you know, what is expected from WellPath? And, you know, that whole, I mean, we got sent the WellPath contract, it's 150 pages. I'm not reading 150 pages of a WellPath contract because I'm not going to get it anyway. So the question becomes, how do we get informed so that we're all understanding and coming from a similar body of knowledge?
I think I'm gonna suggest the same thing Daisy did, that if you want to learn about the DOC, before we go into the next meeting, we look at their website, right? I mean, as legislators, some of our work is done outside of this room. And, you know, I am gonna peruse the contract. If you're interested, peruse the contract, come up with a list of questions so we can, you know, continue the conversation onward. And then Leslie, I would also say, you or anyone else, if you can call Annie and set up a separate meeting if you'd like, and have that conversation. We are going to get to the point where we understand the prison system.
Right.
It just may not be in a clear line path.
So but Annie only does mental health, right?
But she can connect you with the.
Okay, because that's sort of the issue. I felt like this was really a mental health focused conversation, but I was curious about physical health and how, because complaints I've heard about people not having their diabetes treated appropriately, and that's an issue.
Yeah, oh, totally. That's why we're doing this.
And I'm a little nervous about the website. I get that I can learn how many prisons there are, but it's the underneath part of.
So what I would suggest.
I mean, I'll definitely do that, but.
Is you come with your list of questions to these meetings, and if they don't get answered as we continue on, we find another way to get them answered. But this, I mean, it's it's all new for all of us. I don't know the prison system either.
So that's what I'm struggling, sorry, but that's what I'm struggling with is I'm not sure I get the goal. And I'm trying to understand that. I can understand the prison system.
Our goal is to determine if there is a problem with providing healthcare in our prisons. And if there is, where the issues are, and then how do we fix them?
That's pretty big.
Yeah, very big. That's why this is not a.
That's why
you
I'm
know,
overwhelmed.
Yeah. So we're gonna take it in chunks, right? And then Mari.
And I apologize, this was discussed in the.
No, it's fine, because you weren't here. No, this is good.
I was just curious what initiated this process? Is it like was it the things that happen in the news when people dying? Was it like a charge that we do annually? I just didn't know what initiated.
How did it come to joint oversight? Remember?
It came from last year.
It was a bill.
Last year, they were having problems
Okay,
with the other contract,
okay.
not providing what they were supposed to do. And there's a new contractor now.
Okay, so that's.
I shouldn't use the word unfortunately, but just so you know, this new contractor is the contractor that was there before the middle contractor.
There aren't too many people that.
And they had some problems.
Yeah.
They learn.
So this contract that they developed
And then
this year is
Yeah, of
supposed
course,
to
yeah, I just wasn't sure.
take care of that,
Yeah.
you know, what they did wrong the first time.
Okay.
And what the second contract, the middle one.
That good?
Yes, perfect.
Mari?
Thank you. I think it would be important to use expected standards of practice for providing healthcare in correctional systems. Every healthcare group, whether you're talking about anesthesiologists or cardiology nurses or correctional healthcare staff, there are national standards of care. And I think we should be looking at that at least for a foundation when we're looking and listening to what WellPath tells us and what the Department of Corrections tells us is happening, particularly around, and we should hear from correctional staff in the infirmary. Again, looking at expected standards of care, and are any of the problems related to not meeting those expected standards of care. So we have objective and independent information we can use. If you want, I can see if I can find someone that might be able to testify on that. We can talk offline.
Yeah, let's talk offline about that. Thank you, Claire. It's sorry, Mari, it's a little loud in the hallway. Yeah, I think that's a good suggestion. So let's talk about that offline.
Okay.
It's big. It could be big. It could be multifaceted. It's not something that we're going to solve this year. So we're just going to go on this journey together, and we'll do some of it with House Corrections. We'll do some of it on our own, and we'll talk as we go, and do the best we can. Easy.
I share kind of Leslie's like, oh, wow, this is a lot. It's a big bite. But I also share I think everyone's interest in it, because I think this is part of our role of providing oversight, and the fact that there is healthcare happening in prisons and nobody really understands, nobody on the healthcare committee really understands the quality of it, how it's delivered, but we all know that it's not the quality that most of us probably hopefully have access to. I don't know, and I just want to say thanks for helping us to stay in the loop and provide the oversight that we know is really needed.
Yeah, thank you. I think it's needed. Just come to me if you're like, this isn't working for me, and we'll try and move forward a different way. But we're just beginning. So let's give it a couple more meetings and see how things go. I was going to say something else, but I forgot. But thank you.
Let me say something while you're thinking.
Yeah.
This has been a historical problem. And it's been there for a long while. So digging into it after what we did this summer it's going to be a way that we can make some recommendations. If they're not in the contract, we can make some recommendations and we can provide oversight of what we're recommending.
Right.
So then, next summer, when we're meeting, we'll have that information to give to that Justice Oversight Committee.
Yeah. And you know, what we do is multifaceted, right? I mean, healthcare isn't easy. And so we tend to break it up in pieces when we are in here in committee. And so this will just be a different, broader way of looking at it, so.
You say anything about the amount of money, just the budget, the size of the money as compared to the rest of the healthcare system that goes toward healthcare in our prisons?
Right, so we spend.
There's no Medicaid, so this is all
Right,
general
this is
fund.
all general fund. I think it was 180 million a year. The WellPath program WellPath contract is 33 million a year, right? And we spend, what, $6 billion on healthcare? But is this general fund, right? So you go to like, what else could we be using this money for if we were able to have Medicaid, right?
And Medicare.
And Medicare cover this, right? So, or if the $2,100 per person per month that Alyssa was kind of getting to in the meeting just seems really large. Why is that? And people are saying they're not getting the care they need. So
Yeah, where else would we spend $33 million a year and get these kind of health outcomes?
Right.
All I say.
Right. We're completely outraged, right? Yes.
Well, we are, so.
Yes. Abby?
But just also, I think Representative Hedrick brought this up, that they're a for-profit company and we don't allow for-profit into the rest of the health insurance sector in the state. So that's another problem because that just, it means that they're looking at their shareholders and not our prisoners. So that bothers me too.
So we actually do allow for-profit in the state. The system has chosen to be nonprofit, but there are some for-profit.
Like the Medicare Advantage.
Right, or there are, other providers that are for-profit, but the hospitals are all.
And Blue Cross Blue Shield is nonprofit too, right?
Yes.
It's also nonprofit.
MVP is not.
It's for-profit.
I think it's for-profit, right?
Okay.
Although it's is it? I don't know.
New York State, so.
Yeah.
No, I know. I just remember that.
But yeah,
I had
but-
nonprofit in health insurance, but I'm
But you're right. Why, we tout that most of our healthcare in the state of Vermont is nonprofit. Why is that for-profit?
I thought as a first step, I enjoyed that. Meeting very much. I learned a lot and I thought it was well presented.
Great.
And who knows where it'll lead.
Right.
As the first step, it was great.
Exactly.
I thought.
Good. Thank you. Anything else before we call it a day?
I guess I would add just one more thing.
Sure.
As we go through this, and we haven't even talked about this, but there's a probation and parole system too. And I'm sure that we're going to dig into that to find out.
Probably.
When an inmate comes out and they're on probation or parole, they're going to talk about what happened in the prison. Probation parole officer is going to be checking that out. Because what happens to them is they're going to do a hell of a lot more work if it doesn't get done by the contractor they're supposed to be doing it.
Right.
They're supposed to know how to do it. Probation parole officer doesn't know that. So that's an area that we're going to have. That's going to be part of our questioning and learning and oversight probably afterwards.
Right. It's not going to be a simple meeting or solution.
But it's important work.
But it is important work. Thank you. Yes, it's very important. So tomorrow we start at 9. We're going to vote on the occupational therapy and the social work bills. And then we have a fun day of insurance claims processing. So get ready. She's the only one that's excited. But this is an issue that started at the end of our session last year, where there were some changes made by the insurance companies that have really impacted providers. And so we're going to start the conversation tomorrow at 10 with education for our committee. We're going to have some providers in here that will walk us through what this is, how they do it, how they've been affected. So it's going to be dry and it's going to be weedy, but it's really, really important. Except for she'll think it's going to be great.
So, just tell me, what do you want us to get out of it? What's the question that we're going to try and answer by this?
We need to understand what the providers have to do in order to bill for a service they provided, and how the insurance companies changed that and the impact it had on them. We're going to hear from the insurance company and we're going to hear from DFR.
Right.
And then we will have a bill. Alyssa and I have input a bill that has not been introduced yet. Part of that bill has some language around claims edits. So this is education for us to understand the process and the problem before we look at the bill.
Thank you.
Yep. And then Thursday, we're here at 8:30. We are actually not here. We are in room 270 in the pavilion, and we will be there all morning with Senate Health and Welfare. The afternoon, we're doing DEVA budget adjustment. And then Friday, we're doing budget adjustment.
Thrilling.
I know.
That's thrilling.